about 30 seconds. We're just going to give everyone a chance to get into the room. Apollo Advisors back again with Dr. Paul Huddleston, Dr. Mike Lefebvre, and everyone's favorite hygienist, Caitlin Parsons. So again, we're going to wait for everyone to get into the room. We're at about 100 people now, and we're going to let the room kind of fill up so everyone gets the same messaging. I'm going to cover the housekeeping as you guys are coming in. If you have questions or comments, please put them into that Q&A box on your screen. That Q&A box is what we're going to review for the questions, not the chat. The chat scrolls too quick on our end. The Q&A box, it's going to put them in a queue, and we're going to address them one by one, and that's Mike, Dr. Paul, Caitlin are going to address all those questions for you. So as everyone comes in, I definitely want to thank you for coming. This is part 3 of the Flipping the Switch series with Apollo Advisors. We get big attendance for this. A lot of people want to join and see what Dr. Mike and Dr. Paul have to say. And again, I always tell people it's pretty exciting because, Dr. Mike is a practicing dentist. So he's not a consultant that's just talking in theory about what can happen. He's actually a practicing dentist. He's getting to reopen his California office, and he's doing a lot of research and due diligence as to what it's going to take to reopen and what he plans to do. And he's been nice and gracious enough to go ahead and share that information with us as well. So with that being said, we've got about 150 people in the room. We're going to go ahead and get started. Again, please put your questions and comments into the Q&A box. And at the end of and actually we just have our first question. So thank you so much. Keep putting them in there. And at the end, we're going to go ahead and address all those. So without further ado, I'm going to mute my microphone and sit back and enjoy this presentation. I've been looking forward to this one all week. And I'll let Michael, Paul, and Caitlin take it away. Thank you, people. Thank you.
Thanks, Jonathan. Thanks for having us back. So we're back for Flipping the Switch Part 3, rebuilding your schedule and patient base, and kind of an insight to our philosophy on how we do treatment plan presentation, which not only applies to post-COVID return, but anytime we're practicing. So the previous one, if you were with us, we talked about rebuilding your facility and your patient base. I'm sorry, your facility and your team. And we recommend at least a 2 to 3 day warm up on that prior to flipping the switch and opening to get your team on board, getting scripts in place and so forth. And that's all available on our Buckets website, which we will preview in a moment. If you need to get that information, just email us at the end of the presentation. We're more than happy to get that complimentary information to you. We update that pretty regularly. So when we're getting emails from the CDA and ADA and so forth, updating the moving target, we try to keep that updated for you. We also have information on air filtration systems, how to intro on how to put an N95 mask on and so forth. And then this week we updated the entire CDA resource kit is actually on there with all the Google Docs as attachments. So you don't have to have them on your computer. They're right there for you to access. So let's move on. So the question is always the same every time we begin is, when are we going to be open for business? I'm sure we're all following that on a daily, if not hourly basis. And we still cannot get a message from the governor as to when we're going to open. There's a lot of states that have already opened already. We all know that the main issue is getting proper PPE in place for both the dentist and the hygienist. Hygienists are very concerned, particularly because they're producing aerosol in their current state. In our previous presentation, we recommended that they not use ultrasonics from here on to minimize that aerosol, but there is going to be aerosol in the dental operatories, obviously, and so proper PPE is going to be recommended. They recommend, the AD recommends a KN95 or N95 mask or a level 3 surgical mask with a, there are face shields out there that will actually go over your loops. We haven't tested those. We've seen them advertised, and I've heard that they do work. So that could be an option for you. So contact your dental supply reps for that information. These are in short supply, and they're also, in order and available on a regular. So we are getting our PPE actually this afternoon. Is going to be delivered to my house. So moving forward. So first and foremost, welcome to Buckets. This is the platform that Apollo Advisors works on. It's basically a practice management or a project management online program that allows to house all of our information. And it's a great tool for your practice, for you to get all of your practice resources for your team to be able to go to. Also allows online collaboration once you get things up there. So go to buckets.c to be able to get an account and move forward. It's free. So starting off, we always start off with the numbers. This is May 1st, 2020 in the state of California, and shows this is the death curve actually for the state of California. And kind of mid to late April and a little bit, and now we're kind of back on the rise again. So the way it was set up was we were supposed to have 14 decreasing days of cases and deaths before anyone was going to reopen, and everyone's open away, and we really are not on the side of the curve. So but the good news, especially in San Diego, that we have not overrun the hospitals really in any area. They've got plenty of PPE in the hospitals, and they're not overrun from a ventilator perspective and so forth. So that's good news that we have not overrun the health system. Reopening, we'll see what happens as we reopen, and other businesses as well. So here's the science roadmap stages. I'm sure you've all seen this last presentation. We got the 4 stages. We're currently now in stage 2, where they're doing slow opening of low risk workplaces. We do not qualify for that. We're actually in stage 3, and we will not get to stage 3 until we have our PPE. And so that's always the end, is where is it coming? So we had 10 million masks that were promised to us for the California Dental Association dentists, and they picked them up, and then the governor's office put them back, and we had to get them back so the hospitals could use them. So we were kind of left high and dry, and now we're kind of fending for ourselves, and the reps have been working tirelessly trying to get us our PPE so we can open. Again, we're at stage 2. On to stage 3, that's when we can open. You want our best guesstimate? I'm thinking end of May, early June. Here's the Return to Work Interim Guidance Toolkit put out by the American Dental Association last week. We actually have that on our Buckets project under Flipping the Switch under the Practice Resources. So if you need, just let us know. We can send you to that, and you can have a free link to getting the tools, as well as the CDA resources as well. So last time in part 2, we talked about rebuilding the team and rebuilding the facility. So we're going to assume, as we move through the information today, that your team is rebuilt, meaning that you've had your team 2 and 3 day. Obviously, we probably haven't returned to work and done that, but real important that you kind of set the ground rules of hiring, your practice moving forward, practicing the PE, donning and doffing so everyone is safe, going through scripts for the patients so they feel safe and at home, and that you really have an optimistic attitude moving forward. So that's the first thing, is to rebuild your team and your facility. If you need more information on that, again, on the Buckets project, we have all the checklists laid out of what you need to do to be able to achieve that. So moving on to scheduling. So the scheduling strategy moving back is the same as if you were... Have an audio problem? Okay. Okay. The scheduling strategy is the same following any long break or long crisis. We have to rebuild hygiene, and we have to rebuild the dental side of the schedule. The hygiene backlog, when you look at the downtime, when we gave our first presentation, it was so long ago that we were optimistically thinking that we might have a May 1st opening. That came and went. May 15th is going to come and go, and we're now kind of at that June 1st optimistic deadline, or optimistic opening day. And looking at if we had 8 patients a day in hygiene with an 85% scheduling rate, meaning out of 8 or show up at 4 days a week, you're at 272 lost appointments from the May 6th or March 16th closure up until that point, or 12.5%. So the question is, we got to get that ramped up and get patients back in the queue. So first off, we want to be able to look at kind of hygiene scheduling ratios. And so we essentially have preventative patients, which kind of fall under that 1110 preventative category, or prophy. And then we have periodontal patients that fall in the periodontal category, or 4910. These are the patients that have completely lost an appointment. They were due in late March and all of April and then going into May. And so when you see them in June, July, and August, you're actually going to be seeing them for their appointment that they're 3 months overdue. So we're recommending that you stack your schedule in May, as you can see in dark blue there on the bar graph. Those are all periodontal maintenance patients. I would have your office manager call and schedule all of those patients first so we can get them in the queue, get them treated, and then get them reappointed in September and then again in December, so they're not going to be missing any more appointments. They're the ones that are going to be the most needed care versus a preventative prophylaxis patient. It's also a more productive appointment, so you're going to see the bottom line increase. You have your periodontal patients come in first. So when you see to June, we kind of have down into 90-10 and then kind of go into 50-50. And then in August, kind of returning back to that February, March bar graph. And that's just basically breaking it down as if you had 70% of your patient base as in prophies and 30% in perio. And so you just want to kind of change that as you go through. A lot of doctors have expressed interest in stacking hygiene and having a lot more hygiene days to get patients in. And that's one strategy, if you have the room to be able to do that, can work. We will caution, though, you're going to have some bottleneck issues because you're going to have to see one patient at a time and probably call them from their car in and, have social distancing and so forth. So that may not be the wisest decision in the beginning. So it just kind of depends on what your demands are.
Hey, Mike, before you move forward there,
yeah,
maybe Caitlin can jump in here too. In that periodontal maintenance appointment, a lot of those periodontal maintenance patients are used to a Cavitron or an ultrasonic. By not employing the Cavitron or ultrasonic, how's that going to affect the longevity of the appointment? And have you talked, Caitlin, do you have any thoughts about extending those appointment times if you're going to be doing hand scaling? I'm just curious.
That's something that as hygienists and as dental offices, I think is so important and we need to consider. Dr. Mike and I haven't talked about that in depth. I'm curious to know what he thinks, but there is, for those scaling patients or those perio patients, there's definitely going to need to be a longer appointment for certain ones.
For sure. We're fortunate that we have a couple extra rooms that we can kind of trade off those patients or schedule those patients sequentially. But that's part of the team 2-3 day, right? Is to get in there and start role playing, and maybe clean a team member's teeth the old way without the ultrasonic and see how long it takes. I mean, just donning and doffing PPE is going to take some time to get used to. So we're going to have to make accommodation. So it could be something to where you have another team member or assistant is flipping the rooms for them, and that's going to save them 10 minutes. And so they might be able to utilize all of that time to the top of the hour rather than having to flip the room. So that might be an option as well. But yeah, I've got that on the checklist of what we're going to do as far as approaching that. So that's a great question.
I think we're all on mute. Mike, are you guys ever on mute?
Yeah, Mike, Dr. Mike, you're still on mute. I don't know if you know that.
Paul, you want to chime in and fill the void for us with a little commentary?
Yeah, I can sing a song. I've been known to do that at times.
I'm back on. Sorry.
Thanks, Mike, because I was just about to cue up the mic there.
So had just having a few issues on the advanced slide. So see, we have the same issue again here. Okay. So how do you increase production in dentistry? So there's only two ways to be able to really do that. Is you either increase the speed in which you do the appointments. Caitlin just chimed in with regard to it's actually going to take more time to do hygiene appointments. But you can increase the speed, which is kind of self-limiting and the law of diminishing returns because you can only work so fast before quality starts to suffer. Anyone who's worked in corporate dentistry can attest to that. Or you can look at the production per patient, and that's what we're going to focus on today. It's really what you do during that patient hour or however long you're going to be there that's going to affect your production long term. And we're going to kind of lay out for you some key points and plans today to where you can not only increase the production for patient, but get the patient engaged in their overall treatment plan to where now when they're coming in each time, you actually have a plan that's going to be productive. The most unproductive way is to do one tooth at a time. The second most unproductive way is to do two teeth at a time. So if we can start to look at comprehensive care, that'll be beneficial for all. So we've, professed since our first presentation, gosh, over a month ago, that COVID is really just another crisis. I mean, I know it's affected everyone, it's affected all businesses, and we've all had stay-at-home orders and so forth, but I think the reaction moving forward is going to be the same, meaning that bad news causes patients to be hesitant. They're hesitant for the bad news. They're hesitant because there might be some financial constraints, certainly going to be financial constraints for a lot of patients coming in. So we really have to be sensitive to that and really be able to give them a plan moving forward and to guide them based on their risk of what's the best way to move forward. So you want to choose your way out wisely. You want to really think about and appreciate these patients that are coming in and guide them through their healthcare throughout this time. So this will pass over time. It's just a question of when. So you want to be their dentist when they are ready to actually receive treatment. So in scheduling dentistry, number one, we recommend call and book all previously booked patients first. Those are the ones that were on your schedule in March and April. They're waiting to come in. There's no reason why they shouldn't engage and schedule their appointment. That will give you some vital information as to how much readiness they have to schedule dentistry. If you start seeing people pulling back, then you need to make some decisions on adjusting the schedule accordingly. But Charlene, my office manager, has found that people are more than eager actually to come in. So we're kind of surprised that so far it's looking pretty optimistic. So we're going to have everyone scheduled first for them. Book big appointments using block booking method. Hopefully you're all utilizing that to where you pre-block in your early morning hours to where you can hold those high production appointments. That's the key to getting your daily on that. Set up a same-day treatment room. If you have a room in your office, the key is going to be strike them when the iron's hot when a patient comes in and they need treatment. So you want to be able to provide that same-day treatment for a couple of reasons. One, you're keeping them safe because they're not going to have another exposure to the office. And then secondly, you're being able to provide that treatment the same day is productive for you, but it's not going to be inconvenience for them as well. They have childcare. They probably don't have nearly as much PTO time to be able to come back in, and going to the dentist, frankly, if you ask patients, is really kind of an inconvenience. So we should be doing same day treatment anyway, but really try to get your systems in place where you can provide that. Recommend that you have restorative tubs ready for the same day treatment. So, if a patient is in Caitlin's chair, for example, I can give her the cue. We treatment plan the case or the filling. She could give anesthetic at that point. We got the room ready to go, and we're rocking and rolling in a few minutes, and we can have that patient out the door. Make sure you practice your financial arrangement presentation. In this case, the patient's probably not going to come up to the front. Remember, we're going to have completely different rules now with regard to patients interacting with the front staff. In our previous presentation, we recommended that we start to get credit terminals in the back, and we have kind of touchless payment options or even collecting in advance, so we can eliminate those touches between the patients and the office manager. So here we're talking about if we have same day treatment, ideally we want to be able to have the financial arrangement done in hygiene or in the restorative side, and have that done and just kind of it almost be an afterthought that they sign the treatment plan and then we're ready to go, which will minimize the amount of time. And then make sure you have your financial options instantly available, meaning that if you have care credit or if you offer any type of, 2 payments for a crown or something like that, just you have those ready to go so the patient doesn't have to leave the chair. It's all about convenience and efficiency. And so the patients are going to make emotional decisions, and we're going to touch on that in a moment. But really, it's all the decision is always an emotional one, and they'll make it in an instant. And so if you're ready to go, likely they will consent to treatment. Again, just kind of highlighting the block booking, 75% of your daily production should be done before you go to lunch. And you can see kind of in the blue and the green, this is what we do. This is typically like CEREC procedures that we do. And we staff where we have most of our production completed by 1 o'clock. We hold that block for up to 48 hours prior, and then we start to fill with other procedures if that's not filled. So none of that happens unless we get to yes. So the rest of the presentation is really going to be addressing this, is how do we get the patient to yes? And there's really only 3 obstacles to a patient saying yes: that they don't have enough time, that they have fear of dental treatment, either fear of getting the needle or fear of pain, or, you know, previous experiences that they've been carrying around with them. They really don't know why they're fearful, but it's really not a pleasant place to be. So, you know, we all know that's an objection. And then finally, financial options or financial constraints to where you don't think that they can afford the treatment, or they can afford the treatment. So we have to be able to address those 3 obstacles before we can get the patient in the chair.
So Mike, I think I'm going to take it from here for a little bit, but please chime in. You know, it's so tempting, I think, for us to be on turbo mode right now and think about getting back into the office and making snap decisions about how we can maximize our productivity. Obviously, we're coming off of a month and a half or 2 without having any type of revenue flow. And so that's fueling a lot of our decisions. And I imagine a lot of people are impatient right now. I think it's important to note that when we make rushed decisions, we tend to lose money. And so instead of focusing on the outward attempt to secure a new patient, I think we should look inward and foster and coddle the relationships we have with our existing patients. So we like to talk about the loyal patient experience as being a primary mover in our practices. Go ahead, Mike. Thank you. So I think it might be intuitive, but it's nice to point out in a chart format what a loyal patient looks like, a loyal existing patient versus a new patient. And if you think about the cost that is required to obtain a new patient when advertising costs, and then the costs involved with bringing that patient into the practice and establishing trust and so on and so forth, cost is quite high. But when you have a loyal patient who believes in what you're doing and understands the rules and concepts of what you're trying to employ in the practice, the cost is rather low. So there's just a night and day differentiation between that loyal patient and new patient in terms of cost. You've already established trust. You've worked hard to establish trust with your existing patients, and it's important to continue to move forward with the trust, establishing that trust. Never take that trust for granted. Continue to try to foster that. We have habits that we have to follow in our practices. And when it comes to patients, they're used to 3 types of habits in this habit loop we call. And one is the cue, one is routine, and then the final one's reward. And when we think about the cue is simply, how do you get that patient into your office again? And we all have ways to do that. The old way used to be postcards, and we know that's passé now, except for probably 1 or 2 patients in our practice who prefer that. But we have text messaging, we have automated systems to do that. And then they come in and they expect a routine. And that routine is very regimented when it comes to that every 6-month visit or maybe a periodontal visit. And Caitlin can probably attest to that. There's certain things that patients look forward to. There are certain aspects to the appointment that they expect. And then there are certain ways that they leave the appointment, and that leads us to reward.
If I can chime in, Paul, there's actually a science behind it. That's why I put up the book. It's a fantastic book, The Power of Habit, and it's the science behind why we develop these habits and do the things we do. And that's where the cue and routine and reward came through. And it's amazing. And he goes through the cue, routine, reward for personal, for communities, and for business. And if you really want to see the science behind it on why people make decisions of doing habitual things, I highly recommend I put it up there.
Thanks, Mike. Yeah, it's a wonderful read. And not to get into the mindset here that cue, routine, and reward never changes over time. Cue, routine, and reward is a constantly evolving process so that patients, while they are secure, they also can be moved in more positive directions. So if we think about analyzing the routine and the reward and varying that for our patients, we make it a more dynamic and positive experience, and we ping those serotonin receptors in the brain when we do that, and that further entrenches them to liking our way of doing things.
Hey, Caitlin, do you find as a hygienist when you're working in the office that patients are looking forward to the goodie bag or what's in it if there's something different this time? Do you think that that's worked? We've kind of worked pretty hard to get that reward. I know the reward is the hygiene appointment, and sometimes the reward is seeing Caitlin and catching up and seeing what she's doing, and they're sharing stories and so forth. But what's your thoughts on that, Caitlin?
I mean, yeah, the conversation with me is always their reward. No, I'm just kidding. We have a lot of patients that look forward to the little pieces that we give and touch points. I don't know how many patients, when we gave those chargers out, like on-the-go chargers, how many
USB
people
charger?
Mm-hmm. Yeah, how many people came back and they were like, I still use it, thank you so much. So I think that's a big part of building our loyal patient base for sure.
It's amazing to me also how little changes can set a patient off. In my career, I purchased 3 practices and merged them into one office, and each of those practices had its own complexion. And when I purchased my first practice, it was from a dentist who was retiring. He was 65 years old. Had worked for about 35 years. Very gregarious, wonderful guy. And he had this infinity mirror in the reception area. And it was the most hideous looking infinity mirror of anything
I remember seeing that.
and it was smack dab in the middle of the wall. And when I remember when I first looked at it, I got dizzy. But anyhow, one of the first things I did after I purchased the practice was remove the infinity mirror. Thankfully, I kept it in storage for about 3 weeks. Because I had so many people actually approach me and say, what did you do with that mirror? I miss it, and it's terrible that you took it down. And it just goes to show what patients look forward to. And it might not seem like anything to you. In fact, it might seem rather strange. But there are certain routines that people engage in, and for some reason makes them feel welcome and secure. And that I'll never forget that.
Yeah, exactly. And it can be as simple as the old way of the reward was the toothbrush, right? I remember, gosh, probably 10, 12 years ago, we kind of switched our philosophy from hand toothbrushes to sonic toothbrushes. So we moved to sonic hairs, and, the rep pointed out, are you handing out toothbrushes to your patients? And we said, yeah. She goes, mixed messages. Why are you handing out a hand toothbrush to your patient when you're recommending a sonic hair? And I went, oh, that kind of makes sense. Well, she goes, hand them a tongue scraper and a floss threader or something, and so we end up going to tongue scrapers actually and something else. And it was well received. And I still remember, like 3 years ago, it was actually in Caitlin's room, and it was a long-term patient's been coming to me twice a year, like clockwork. And I said, do you have any other questions? He goes, yeah, dude, when do I get my toothbrush? And he didn't say a toothbrush, he said my toothbrush. So, I mean, that was the cue, routine, reward to what he expected coming in. So really, we bring this up because they're calling you for a reason, and there's, we obviously have our systems in place to be able to do that and that routine, but mix up those rewards. Look, in the practice solutions books and smart practice to find really cool things and be different. And every 6 months we change that, whether it's a lunch bag or something. So, but you want to make it fun and rewarding when they come in. And follow the lead of others. No one has mastered this better than Starbucks. Now they have the unique position to where their cue, routine, reward involves caffeine. So there's nothing better than, you go and get coffee and caffeine is sitting in the cup at the end. So, and they're running into the same struggles we are, right? They've closed almost all of their stores, and they have drive-through only. And Paul, isn't your brother-in-law a regional manager at Starbucks, and they're kind of facing the same kind of questions we are as how they're getting patients back into this routine?
Indeed, he is, and they are facing a lot of hurdles right now. One of the hurdles was really interesting to me when in talking to him, and he manages 20 or so stores up here in the Seattle area. One of the major issues was employees who had never donned a mask were now being asked to do so as part of their routine, and a lot of them were having trouble doing that. Now, in our environment, we're very used to that. It's been part of our routine for forever.
Right.
But for them, the simple request or actually command to wear a mask was a huge challenge, a huge hurdle for them. And so, in that environment, they're finding difficulties in terms of instituting new measures. But what was interesting in my conversation with my brother-in-law about Starbucks and the way they are delivering a product is that they're starting to open up drive-throughs, and when the coffee, it's unidirectional. I mean, their product delivery is so seemingly simple, and yet they're spending so many resources trying to train the team to convey the message that that cup of coffee, which is going from the barista to the car, which is a very safe environment for customers, has been handled pristinely and with the utmost care and sterilization or cleanliness as possible. And they are taking such careful measures to make sure those routines and those messages are being made. I said to him, man, you guys have it easy. You know, with dentistry, it's bidirectional or multi-directional at best. And so,
And they have a very desirable product.
and the reward with this product is a caffeine hit. I mean, here we have scalers and injections and all that to contend with. So, it's a different experience, but obviously we're gonna get there. But
yeah, and we bring it up because start looking at the other businesses and what they're doing right. We shared this last time in part 2 of the Tale of Two Grocery Stores on Trader Joe's and how they're just doing everything perfectly. And then I went to Vaughn's and not so much, and now I've got my new store, but it was just amazing. It all comes from management and leadership. It all starts from the top down, and then you have rock star employees, which obviously will carry that out. But without the leadership like Starbucks, and I went through a drive-through yesterday, I mean, it was flawless. You could tell that they had practiced this for a long time. So definitely practice. This is going to be brand new, regardless of what the experience is of your team members and the leaders.
Right. And one thing I'd like to point out too is that in our past conversations over the last couple of weeks, some people have asked the question, well, what do I do with that employee who just doesn't want to get on board? And I like him or her, but just doesn't want to commit. Well, at first you might want to, just say, hey, look, everyone around you is doing this. And what's your favorite store to go? Well, maybe it's Nordstrom's. Well, take a look what Nordstrom's is doing. And even they're not even in a healthcare environment. Take a look at what they're doing. And I think you can step up too.
Yeah, absolutely.
So we have our not so fictitious patient, Shelley, who is in our office, and she walks in and we've been able to be fairly confident in knowing what to expect from Shelley in the past. And the fact of the matter is things have changed, conditions have changed, and she might be having all sorts of different questions and concerns in her head as she walks into our office that we haven't really had to address before. She might have hated shots, long ago or maybe all along, but now she has concerns about caring for her sick grandfather, or maybe she has lost a job, or maybe her spouse has lost a job and money's tight right now. And she can't take time off work and stress is high. So, Shelley's thinking about different things, and we have to, I think, try to take a step back and put ourselves in Shelley's shoes and go forward with the mindset of seeing the patient's experience of the office through their eyes.
Yeah, and all emotional thoughts, right? And that's what we're going to get into this in a moment. But we as dentists tend to be very logical people, very methodical people, very step 1, step 2, step 3 people. And we tend to present that way of, here's the problem, here's the solution, when would you like to schedule? And what you see here is just an example of all the things that might be going on in Shelley's head. And these might be issues that she has now. These might be issues that she had before. I mean, I think that patients always grapple with that, right, as they're being presented treatment. Remember, they're usually coming in to see Caitlin, and they're hoping that they see Caitlin for an hour, and then they get to leave and see Caitlin 6 months later, and then I come in, or Caitlin identifies things, and then I come in, and then we give them the news. And so they're always kind of grappling with that. And so we're going to kind of show what our approach is, which I think really plays in well to this crisis, because there's never a better time for you to start practicing a way to where you can involve the patient to be involved in their care.
One of my favorite quotes, Mike, is from To Kill a Mockingbird, where Atticus Finch says, "You never really understand a person until you consider things from his point of view, until you climb into his or her skin and walk around in it." And, what it struck me the other day when I thought about that quote, thinking about a patient reclined in a dental chair, looking up, the light is in her eyes, and she's just been treated by Caitlin, a hygienist, and now Caitlin's going off to grab the dentist. And in that moment, when Caitlin leaves the room, all of a sudden, patient's thinking, "Oh my gosh, I know we talked about it last time. I know we talked about it the time before. I need to have these 2 crowns done. I really don't want to do it." And all of a sudden, that emotional side is kicking in, and that hesitant side, and the walls go up, and this great time that she's had with Caitlin, talking about her life and sharing as she usually does, all of a sudden comes to a stop. And the brain,
oh, it's you.
And the brain shifts, it's you, and I need to confront this. And the way it's worked before is that I just said, well, I had this excuse, that excuse. Well, now the excuses are a little bit more pertinent, and we can't, as practitioners, can't assume that, oh, it's just another excuse. we need to be really cognizant of the fact that this person has real feelings and needs to be heard and listened to.
Absolutely. So let's kind of look at the old traditional model. A patient presents, right? That's what we all learn in dental school. We literally were identifying problems, diagnosing problems. Back then, we got high acceptance because patients were usually there for price. But we kind of carried that same model through. We identify the problem, we present the solution, we have risks, alternatives, and benefits to that solution, right? But it's always based on the solution. Then we start to get an objection or questions. Is the insurance covering it? Gosh, it sounds expensive, no pain, no problem, and then you've heard, every time I come in, it's something. Or you might have interviewed a brand new patient and I go, "Why are you leaving your previous dentist?" They go, "And every time I go in there, he recommends things that I don't need." And that's simply just a disconnect in communication between the dentist and the patient. The dentist probably has diagnosed it correctly and it needs to be done. It's just a question that the patient hasn't owned the problem and the dentist isn't speaking in emotional terms to where the patient can get involved. And so there's really kind of 2 explanations. There's logical explanation, to where dentists tend to go to where they start talking about margins and decay and cracks and so forth, rather than making it an emotional explanation to where how it's going to affect the patient, particularly long-term over time. We tend to take the snapshot. This is what you have. Here's our photograph. This is what needs to be done, and you'll get fixed.
And Mike, if I can interrupt for a quick second,
Absolutely.
How often has it happened where you present this treatment plan or this course of treatment, and you almost feel, oh gosh, glad I'm done with that. That's I got that over with. Now I just have to get our patient to accept, and then all of a sudden it's just not enough. There's a big void, and then all of a sudden you start to creep in. The thought creeps in, oh, have I missed something? How come I'm getting this reaction from my patient? It's not supposed to work that way.
Absolutely. As we talked, the emotional side of the brain is in the limbic system, is the part that controls communication. So if we're talking logically and they're in an emotional state, there's going to be a disconnect between it. And so that's where the barriers come up. Now, there's some people that just get work done because they're saying this is what the doctor needs, and that's kind of that routine care. But remember, we talked about how we increase production and quality of dentistry, for that matter, is increasing the production per patient. And the key to increasing your production per visit and your production per patient is to get that patient involved and speaking in emotional type language that gets them involved. And you just never know for sure where Shelley's brain is or what's going on. Paul?
So as Mike alluded to back in dental school, that's where we started to learn how to do things, how to fix problems. And everybody who goes to dental school is probably pretty proficient in fixing problems and has been very goal-oriented in doing that. They've also had a good heart going into the profession too. I mean, most dentists I know, start from a place of goodness or beneficence, where we just want to do good things for somebody. And dentistry is the tool by which we achieve that. And so in the old school approach, back in dental school, is that, okay, well, I learned how to identify a certain problem. I learned how to fix a certain problem. And I'm going to present this to you, and you're going to say yes, and everything's fine. And of course, the patients who come to the dental school are usually coming to the dental school because it's the last resort. So the acceptance rate's super high. But when we get into private practice, things differ. And the hierarchical approach toward this is what you need and this is what you'll do just doesn't seem to work. The chasm that exists between that approach and what the patient's thinking is just too great. So any momentum that we establish in our that's fix-it approach comes to a complete halt. We run ourselves up against a brick wall. Well, that I think has probably been experienced by everybody in the audience here. And there's a way through that though. And that's what we want to talk about today. So how do you break through that wall? Well, it starts with opening up the wall by risk assessment and creating a risk assessment profile that empowers the patient and actually empowers the dentist to have a neutral ground, to give that sense of control over to a patient. And all objections stop when it comes to the assessment, risk assessment profile. When we hand off the baton of what we've created, think of the 4x400 relay and how there are 4 steps to that relay. We create this baton of information that we've gathered through our examination and through our experience. And we show that patient, hey, what does that look like? This is what I'm seeing. And I'm telling that patient, and this is what we're really good at. But what we tend to, I think, fail at often when it comes to communicating with patients is handing off that baton between the tell stage and the engage stage. How we engage with a patient is so important. And it's not just a one-way information track. It's actually a two-way communication process by which I'm listening. I'm intently listening to what my patient is saying. I'm listening to and noticing facial expressions, and I'm starting to get a feel for where that patient is in the moment. And so it becomes less at a point about what needs to be done, but more about how we can work and engage with one another to make this happen for you. Once that's established, we let go. We have to pass that baton off to the patient, and all of the categories of risk that's associated with that treatment recommendation, that goes to the patient. And you say, hey, I'm going to pass the baton off to you. I want you to think about it. I'm always here for you. But when you're ready to proceed, I'll be waiting to grab that baton back from you.
Absolutely. Wouldn't it be great to have conversations with patients to where we don't have contests all the time? We know we've gone in. Caitlin, when we go in, we're talking about the same treatment to the patient over and over and over again. We get that resistance. And we kind of shifted to this risk assessment model. What do you think, Caitlin? About 2 years ago or so? We went to a risk assessment model rather than this problem solution issue. And the one change we made that was just monumental is we started to have the doctor-patient initial encounter, meaning that all new patients that came into our office met me first. And that's really the first and only time that you'll ever get to talk to a patient alone. without presenting treatment. And they start to open up, and you can really start to delve into a health history plan. And, you know, by the way, the dental health history, if you download from the American Dental Association, is not going to cut it. You have to have a customized dental health history to where you want to ask emotional questions to where you can start to get answers. Questions about their sleep, for example, question about their previous dentist, you know, what was their experience, question about their parents and grandparents. You want to start to paint that picture of what the timeline looks like so they can start to understand the risk when you finally get to risk assessment. But I can't tell you how many times we have started treatment planning or started a plan or a lifetime plan for dental health in that initial encounter. And what's so nice is once you have that initial encounter, you're actually given a prescription for x-rays to the dental assistant, which is required, by the way. You can give prescription for photographs to be taken by your dental assistant. And all of this is top down and led by the doctor. And once they see that, the acceptance rate by the patient is very, very high. And then there's a rationale for what we're doing rather than bottom up to where we're collecting information. And they're like, well, why do we need that? Why do we need models? I don't need x-rays. But if you start to assess the risk based on starting with their medical and dental health history, you now have a rationale moving forward, and the patient's involved the minute you start the exam.
Mike, I think the word collaboration here really is key. You know, that hierarchical approach that I was pointing out earlier, when we're talking about establishing loyalty, it just is snipped short. It's cut short. But when you talk about a collaboration, when two people are in front of one another having a conversation they probably have never had in their lives with another dentist, it goes so far to cementing that loyalty in that beginning loyalty experience.
It really does. And you set the tone, right? So if your assistant or your hygienist, Caitlin never has a bad day, but if your hygienist had a bad day and the patient was seen in hygiene and then the doctor comes in, it's the same kind of routine as when they've had established care. And you just never know what that conversation was. And, you know, we've had to do that on occasion and it never goes as well. We always start with that initial consultation. And then we start off and then we begin this risk assessment. So when we do an exam on a patient, you know, we're starting to build the loyal patient experience. We want the patient to be loyal. We want them to, in our office, we have the vision of doing two things: develop a lifetime plan for the patient and to get them to refer another patient. That's all we focus on. And so by doing that, we know that we're always developing a lifetime plan. Now, for patients that are young, a lifetime plan just might be preventative, but you want to make sure that cue, routine, reward is in place to where they realize the importance of coming in for preventative care. But we approach it like this. In the initial encounter or the meeting with the doctor, I pull this out and I always say, today during your exam, we're going to look at 4 specific risk factors. We're going to look at the foundation, the gum, the bone that's holding things in place, and the gum. We're going to look at the teeth. We're going to look for cavities, cracks, and wear and erosion from acid. Acid, by the way, can come from 2 places. It can come from the outside of what you drink. It can come from the inside from acid reflux, which could be actually complicated with sleep disorders, which we might screen as well. So you're starting to lay out the plan of all the features and things that you provide without having to do a chairside. And they're in a much more comfortable environment. Then all of a sudden you might hear, oh yeah, I actually had a sleep test, or, oh, I went to the periodontist, and they're telling you things that you never would have ever known. So you're starting to build this risk assessment profile. So when we're looking at it, we're looking at the foundation here. We look at the teeth, cavities, cracks, and acid erosion. And then finally, we're going to look at the bite. We're looking to see how the teeth come together. Now, again, we're talking about COVID and coronavirus, but this is no different. We're talking about patients that are hesitant to come in, possibly, are going to be tight on finances. When they're ready, and you're never going to do dentistry other than emergencies until they're ready. When they're ready, you want to be the dentist that is doing their plan. Now, I can tell you, for the years that we've been doing this, no one has ever said that they've got their previous dentist. So you will separate yourself from the pack if you commit to having something like this and start to build that loyal experience with risk assessment.
Hey, Mike,
Caitlin,
can I ask you a quick question? So,
sure.
I know it's going to come up here, but I'd like it to come up while we're looking at this slide. There might be people out there who would say to you, okay, well, you're asking me to spend an hour or so not being quote unquote productive, talking to this patient, getting to know this patient and laying this out. I mean, how am I going to make any money off that?
Mm.
It's a great question. And all I can say is you have to, it's a marathon and not a race. And, if you're a high volume clinic, to where you're treating and treating, you're seeing a lot of emergencies and not having loyal patients, meaning that you're having to go out and advertise just to have new patients to sustain your practice. Then recessions are tough, right? Because new patients go away. I don't care who they are. The number of patients that are seeking dental care go down in recessions. That's proven. So it's your loyal patients that you want to focus on. And all I can tell you is that it is an hour well spent. Caitlin, what are your thoughts when we started to move this into the hygiene aspect of it? How is the nature of your appointments changed?
Yeah, they've changed drastically. And I want to, before I even go on the on this, going back to like the time that you spend with our new patients, I think is invaluable. I don't know how many patients come to me after, and I hear all the drama or what they like, what they don't like for the most part, and the trust that you're able to build and the connection that you can build as a dentist to a patient. And just outside of that, they start to see your humanness, and they start to understand that you are a human, not just a dentist wanting money, wanting to sell them on certain treatment. So I feel like that has changed, your relationship with different patients and all of that. Yeah.
It really builds the trust early. And look, there are times we don't do this for time constraints or the patient's late and so forth. And every time, right, Caitlin, we have a meeting, we're like, oh man, we got to go back to the loyal patient experience, because it's so nice to where you just don't have that tension. Because once you build the risk, now it's a question of you being the architect and the engineer to be able to give them a lifetime plan and a budget.
Can I just say something? As an office manager and working at different offices with different dentists, it makes a huge difference in accepting treatment plans. And I would say Dr. Lefebvre is the best at having my patients say yes to their treatment, just because he takes that extra hour to make that connection and find out what is their main concern and what they do want to get started on.
Yeah, and it's Charlene joined us as she's my office manager. She joined us on the panel. Welcome. And I'm so blessed to have a team like these guys that can really carry out the vision that we have. And we weren't always great at it, but I'll tell you, when we have this tool, you've got this common playing field to where everyone is having the same conversation in that emotional centered language that the patients can understand. And you get objections. Charlene, share, what are the typical questions you have when you're doing treatment plan presentation, when both with a risk assessment and the traditional way?
Well, I don't get very many questions. The patients are very well informed with Dr. Lefebvre, which is fantastic, because the last thing they want to hear from me when I'm treatment planning is what their treatment is or understanding their treatment. So they come to me with a 100% understanding when they do have that risk assessment, and they talk to Dr. Lefebvre and they go through it with their hygienist, and they come to me and they only have financial questions, which makes my job exactly what it's supposed to be. I'm only there to help them with their financials, get them scheduled. I'm not a physician, so it definitely makes things better. Without it, in the past, when I've worked at other offices where they didn't go through that treatment, they would come up to me and they'd feel suspicious because I'm not a provider. So why am I going over dental treatment with them? And it makes them feel like I'm just trying to get into their wallets.
Yeah. And it's just a system, but it's a system that involves the patient involved in their care. So they understand it. It's more like they're seeing a physician if you were to go with some cardiac problem. And, what do? They assess your cardiac risk. And based on your risk, then you can now make informed decisions on your lifetime care. It's not just a snapshot. The labs are a snapshot, but it's the labs over time that tell the story. It's the photos over time that tell the story. It's the periodontal recordings over time that tell the story. And that really kind of arms the doctor and the team and the office manager to be able to work within that framework. So photos tell the story. So I would recommend, if you are not taking photographs in your office currently, that you start. Get the training. There's a ton of online training. There's a ton of hands-on training out there. This will change your production per patient faster than anything you do. Now, fortunately with Invisalign, that's really ramped it up to where a lot of people are taking photos. But in doing our consulting, Invisalign offices will be taking photos. But if they're not doing Invisalign, they won't take them on a new patient. It just doesn't make any sense because we don't know what the patient wants until they can see what bothers them. And it's those sometimes high demanding patients that might have wear on their teeth that are completely unaware that you just can't show them or tell them that until you start to get photographs and show them where they are and what normal is, that their teeth are aging faster than them, for example. So photography is just absolutely paramount. And again, it's being delegated to an auxiliary member at the initial consultation.
Yeah, Mike, sorry to interrupt you there, but I think it's worth the conversation for dental assistants and hygienists to have with their dentists about what they can do to help promote photography. Whenever there's a suspected problem that just needs to be highlighted or seen better, take out the camera if that's not something that's part of your routine, and actually, capture that problem in real time. Your patient will perk up and actually ask you questions about that, and you can start a discussion prior to the dentist coming into the room. But I would recommend going through your routine of what you do now. If you do use the intraoral camera right now as a hygienist, for instance, think about how you can enhance that routine in one or two ways that will help to promote that visual education.
Can I chime in here?
Sure.
I feel like taking photos as a hygienist it makes my job even so much easier in being able to educate the patient on what's going on, being able to kind of see how things progress. So if something does show up, we have proof, or like we have what it looked like before for some patients. And then there's no arguing with it, right? We get to just take the gloves off. Here's what's going on. And it puts the ball in their court, I think, definitely. And then I'm interested to know you guys' thoughts on, as we move forward after COVID, there's a lot of people talking about, do we think that intraoral cameras and taking photos is actually going to be more beneficial as we move forward? Because is it going to limit the time that the doctor has to come in for hygiene exams, for example? Does that make sense?
Wait, would using the camera the amount of time?
Yeah, or a couple offices were actually saying that the hygienist or whoever will take photos instead of the doctor coming in, unless of course there's specific concerns or
Oh, I see what you're saying. Interesting.
Yeah, Mike, sorry, I don't want to chime in, but we had David Rice with Ignite DDS, and he said his modus operandi is going to be his exams are going to be done later in the day, utilizing all the photos that were taken instead of un-PPEing, going in to do the exam, then re-PPEing to go back to do his treatment.
Oh, interesting. Correct.
I might have a thought about that. I think that the more information you have queued up prior to the exam, the better. And so, Caitlin, if you were to take a series of intraoral photos that I could see from another room, for instance, prior to me walking into your room, it would enhance my acuity in terms of what to focus on, and perhaps allow me not to have to hunt around as much in an examination. So I think from that standpoint, yeah, it's completely beneficial. Any information I could get prior would be wonderful. But in lieu of an examination, I don't know if I would feel comfortable with that. I personally think that there's so many tangible diagnostic problems that can only be felt or seen through touch, and a combination of the two, that I definitely want to be in the mouth. That's my
and it shortchanges the experience, right?
Certainly. Yeah. So for what you propose, though, Caitlin, is a great enhancement, and I would be very appreciative of being able to have that information beforehand.
Yeah. By the way, regarding imaging, they have come down now. The CDA said that CT imaging now, cone beam, is a suitable replacement for traditional X-rays during this COVID crisis. Panoramic or CT. So we can actually actually do that as a substitution will actually maybe save a bit of time with the hygienist, and obviously saving them on the touches of that interaction with the patient. So Caitlin, we actually have that on the checklist that we'll talk about that, but it came down and I read that. I thought that was interesting. I'm excited because a cone beam just provides so much information. Again, the patient is involved in their care, and they're involved in their lifetime blueprint.
And these decisions really go right back to risk assessment as well. If the person is high risk for caries, let's say, you might have to maybe augment the cone beam, with periapical X-rays, X-rays. But if they're low risk and it's appropriate to have that cone beam cone beam image, that'd be great.
Yeah. I mean, just leverage all the technology that you have, obviously, right, on any time. But risk work, it really allows you to hand off that baton from dentist to assistant to hygienist back to office manager. We practice this all the time, and you work out the kinks, but the message is the same, and the patient's got respect all the way through. And I ask all of my patients, why did you leave your previous dentist? And I can tell you that other than moving, or it's usually not an insurance issue because there's not an insurance issue in our office, but the number one reason is they recommended things that I didn't need. They're not a dentist. So how do they know that they didn't need them? Because they weren't involved in their care. So when you go to risk, you can't argue with risk. If I say you're moderate risk of caries, unless you're a dentist, you really can't argue. And so now it's up to that patient to change their behavior. And knowledge doesn't equal change in behavior. Otherwise, everyone would be thin and running triathlons. But at least they've been put on notice and they're involved in their treatment. So when they have to make those decisions, they can make appropriate ones, and usually ones that have comprehensive nature.
Hey, Mike, if I could jump in really quickly here, just for the audience, you might have already experienced this risk model that we're trying to teach you today in your lives. Outside the healthcare setting. I know for instance, we own a Honda Odyssey. We have a bunch of kids and we need to run them around in that machine. And so I'll take the Honda down to the dealership for service. And the very first thing they say is that, okay, these are the categories we're going to look at today. And we're going to give you a report about that. And then when all is said and done, you walk out of here, we're going to let you know what's been going on and what's next. And they're very well trained at presenting in that fashion. And when I leave, I do receive a very nice visual report that is all about risk. And most of it is low risk problems that I might have to address in 1 or 2 years. And every now and then something creeps up into the moderate zone, and I'm aware of it and I acknowledge it. And if there's something that's obviously high risk, they treat that right then and there, or at least get my consent. But they send me off with this security blanket. And that's kind of how I see it in the real world, as an example that all of you might have already experienced. Same thing kind of applies here. So this is not something that you might not have seen before, but just in a different fashion.
And I think this break during COVID has proven all dentistry is optional, isn't it? It's all optional. I mean, they're coming to see you because they want to keep their teeth. They don't have to come see you. Barring a serious infection, all dentistry is optional. So it's our jobs as practitioners to guide them long term. Now, if you want to have quality of life, that's a different story. But all dentistry pretty much is optional. So this is where we want Shelley thinking, right? We want to be talking about her risk. We want to be able to talk about how her consequences affect her long-term. And then now she has kind of a different mindset because our mindset has changed. And so I think this plays really well into us going back to work to where we can really help these patients navigate their care because they're going to have financial constraints and so forth.
So how do you build a memory? And that's, we take our actions in our dental practices sometimes for granted, that what we're doing needs no introspective examination. But building memories is an active process that we can all engage in. Everybody in the office can. And I think it's a great topic for team meetings, to be able to say, hey, what can we do that leverages our uniqueness as an office to build memories for our patient? And one conclusion I came to was being able to identify those patients in my practice that were, the top patients who referred, who enjoyed being there, were very supportive, and then pulling them outside of that setting and one-on-one having coffee or a lunch together on an off day, and just starting a relationship or extending the relationship to that environment, and just asking, hey, how am I doing with you? What do you see as being a real strength in my practice? How am I serving you well? And what could you recommend for us? I really value your opinion. When you put that power into the lap of a patient, I've noticed, to be so appreciated by them, and they will give you input that will be so helpful, and you will solidify relationships with such a memory that you're forming. So when you build
Absolutely. And just to chime in, I mean, Charlene can attest to this. I mean, she's our memory builder from the standpoint she knows every patient, she knows their family, and really gets inside the heads of those patients. And I mean, Charlene, what have you found in getting to know these patients, how it's helped with patient referrals and so forth moving forward?
Well, when I build that connection, it's so easy to talk to them about bringing in their friends and their families, and they look for me when they're calling us into the office. When they're calling the office, they're asking for me, and they're asking for, their husband or their coworker, and it just makes it that much easier. And you can build a really easy connection. You just ask some questions, and they love to talk about themselves. So it's definitely something that I love doing. It makes my day go by much faster when I'm talking to the patients about whatever their interests are, and it makes it easier to ask for a referral because they trust me and they trust the office.
Yeah, thanks. And we bring it up because building the memory is that's what they're going to leave when they leave your office, right? So when you get a new patient that came from a previous office, they have a memory of that office, and there's just a million ways that you can do this. But for example, like a cosmetic patient, you might send them to the spa, and we did that one time, and we had several referrals from that. And you don't know if it's going to work until it is, but you find out their interest and really start to build that memory of that genuine connection, and to keep those patients in. So remember, back to the power of habit, that cue, routine, reward. When they're ready, you want them to choose you for their lifetime plan. So that concludes Flipping the Switch Part 3, Rebuilding Your Schedule and Patient Base. Again, just to kind of recap, we want to maximize our production in both hygiene and dentistry. Hygiene is kind of limited in the standpoint that the fee per appointment is kind of the same in each hour. So we want to be able to stack those appointments with our periodontal maintenance patients, not only for production, but most importantly for their dental care. Want to take the strategy we recommend of increasing the production per patient and production per appointment to minimize the overhead, minimize the patient touches, and again, get them involved. And then finally, put in some type of risk assessment profile that allows them to get involved in their care. So you don't have to keep having these same conversations, and they're really involved. And that's going to be a memory as well. Once you start to get them involved in their overall risk assessment, they're going to be coming to you and hopefully refer friends and family.
Mike, it's absolutely amazing stuff. Sorry, I just saw your next screen. I was going to chime in, but please tell us about how we can get a hold of you.
Okay, so first of all, we always get on the Q&A on how we get the lists on buckets. So if you visit ApolloDentalAdvisors.com, you can put your email in there and we will send you the list. It's just a link to the list of everything we put together over the last 4 to 6 weeks. You can join buckets.co for the checklist and practice control. That allows you to actually edit the list, move things around, kind of like a whiteboard on steroids where there's a lot of cards we can move around. It's what we use in our practice, allows online collaboration of all your team members as well. And finally, we had Caitlin. Caitlin, thank you so much for coming on today, as well as Charlene. Thank you so much for taking time out of your day to join us. Caitlin has her own website, CaitlinParsons.com. And in addition to being a dental hygienist, she's a certified yoga therapist with a special emphasis on dental professionals and how she can help them. I know my back has never felt better in the last 8 weeks, and I know it's not going to feel great at the end of June. And we're going to relax to Caitlin and get on the program.
Excellent information. When I watch this, a lot of things come to mind. And, to me, we're in dental school, we're in our fourth year, we graduate, the banks won't give us a loan for 2 years, and we have to go to work for corporate. And what corporate teaches us is volume. And, when you talk about being patient with your patients, and, Paul chimed in and said, some people might think that's inefficient, but I think it comes back and it builds the rapport and it builds the team and the unit to a great practice long term. And it's great to have that paradigm shift in your career where you realize that being patient with your patients is really going to be what builds this unit and builds this practice to be something that frankly can withstand something like this, the COVID, and the patients are going to come back and they're part of a dental family. So, we're an hour into this and the CE is still eligible. We do have a lot of questions that we can go through. So if you guys have the time and you want to go through this Q&A, let's go ahead and dive right into it.
Absolutely. We also get, questions about what we do and so forth at Apollo Advisors. We are, in addition to being dentists, we are dental advisors. If you like what you heard today, as far as the loyal patient experience risk assessment profile, we're going to start conducting case review communication workshops to where you can kind of learn and navigate that conversation. Bring us your cases, and then we'll just start to have some role play of like how you could present those in maybe a different way. Try a different method and then see how it works. So we're going to have 3 Zoom sessions over the next 3 weeks. We're going to limit 6 people per session, so we have a nice tight group and start to share ideas, kind of a mastermind, if you will, for treatment plan presentation. But really get into this mindset of that emotional language to where we're not hitting that wall every time. We're busy enough, and we're going to have enough obstacles to overcome over the next maybe 18 months, to where let's get our patients involved so they can help us grow as well.
Perfect. And as far as the Q&A goes, I'm going to start off and ask a couple questions. I'm going to have Caitlin answer a couple. And while I'm doing that, Mike and Paul, if you could go through that queue and click the answer live button if you want to address that question, and then you guys can start to throw these back and forth to each other. This Q&A probably should take about 20 minutes. So if everyone wants to bear with us, most of the people are still here with us on the call, so we can kind of keep going through it. Caitlin, what's your favorite intraoral camera for the dental hygienist?
We use, and I love the Digidoc,
yeah.
Yeah, it's so clear, and we had a couple before, but it's easy to use, it's clear, their customer service is good. I love it.
Perfect. And then Caitlin, what are your thoughts about having a treatment coordinator perform risk assessments for NPs?
I wouldn't say our treatment coordinator, well, I guess Charlene is considered treatment coordinator, office manager, but I'd say that in the back between Dr. Lefebvre and then me co-diagnosing for perio, we set it up. So they're just either reiterating what we share with them, but not, or I'm guessing that means actually at the beginning of, like when they first come into the office? I don't know.
Yeah, talking about the risk factors, I think that's probably what they mean. I can tell you that if they can meet you first as the dentist, it just flows the best, because all the prescriptions come from there. It's just like you're ordering labs, right? We need to have photographs, we need to have models, we need to have possibly a sleep study and so forth. It just all starts from that one minute. And then now we start to populate the risk assessment. I assume that the risk assessment, like filling it out, obviously has to come from a provider.
Perfect. And Tom Slezak, the Patterson rep, chimed in and said,
"Hey,
best
Tom.
camera ever, Digidoc."
Seen them all.
Anonymous attendee says, this is refreshing. This is the first presentation where I've heard someone say, let's think about things from the patient's perception. Thank you. So yeah, it is. It's amazing. Someone also says, I'm curious. Go ahead. Can you hear me?
I was going to say that's great feedback. And I would urge you, when you start to do your team 2-day, team 3-day, your preparation prior to opening, that everyone opens the door as a patient and walks through that office in the eyes of a patient and have a clipboard in hand and start writing things down. And you'll just be amazed. I mean, you haven't been there long enough, or you've been away long enough now to where things are going to look a little different. Great feedback that you can get from your team members, and all things go, let them be brutally honest and let them know. And we role play that in our office all the time as we have mock patients and so forth. That's a great feedback.
If I can jump in on one topic that I meant to say, tell about earlier, is that most people have never been away from practicing dentistry for this long. I have, and I'll tell you when I did. I was away from dentistry for 6 weeks back in 2006. My wife gave birth to triplets. And so I was on an extended leave from my office. Luckily, I had a couple of dental associates who could take over. But when I came back, my body was not the same. And yes, I might have been more relaxed in some ways. Didn't have much sleep at the time. But it took about 2 weeks to be able to get back into that same groove, that same level of proficiency from being away. Just like an athlete who steps away from practicing for some time, it's the same type of phenomenon. You go back and you can expect to not be as sharp as you were. It's going to take a little bit of ramping up. And I would remember that when you're asking so much of your team members to be cognizant of the fact that they're coming off of a long stretch of being away.
For sure.
And Mike, you're saying once you have your open date, get them in there for at least 2 or 3 days, full days of training, acclimation, PPEs, staging the office.
Yeah, we're going to do a full week. I'm going to start with Charlene actually next week, and we're going to start getting the administrative portions down. Looking at the schedule, looking at that schedule intently. She's done such a great job. She's been working full time all over this whole period. So she's really been in connection with these patients of what's going on. She knows the type A's, and if you're with us in part 2, we broke down the 3 buckets of patients, and there's the type A's that want to get in no matter what. And obviously those are going to be scheduled, but we're going to work out those kinks that week before. And, I wish we had 2, we just don't have enough time, but we really want to get that fluid, before we open.
And the fact that you have a few of your team members here on this call, I'm finding that a lot of doctors and a lot of staff are chiming in saying, like, no one's talking, no one's communicating anything. Can you talk about the importance really quick of having an open rapport? And if you're out there and you haven't started that communication, and it can start by team member reaching out to doctor or doctor reaching out to team member to start the conversation so everyone's acclimated and comfortable as we begin to start opening.
I'll let Charlene and Caitlin answer that one.
Well, we just had Dental Jeopardy about a week or 2 ago, and that was a lot of fun. So all of our team members are pretty active, and we do have our own little group messaging, and we do stay in touch with one another. So I don't have that as a problem right now, but we're ready to get started.
Yeah, I think it's just so important to have that connection with your team. So you go back and you're again on the same page. Luckily, I've been working with Dr. Lefebvre for just about 8 years. And so I feel very confident and comfortable in what, obviously he's doing these presentations. He knows a lot about PPE. So I feel very supported, knowing and comfortable going back to the office with whatever he decides. But I know not everyone feels that way, or not everyone has that relationship with their doctor. So I think it's just so important as dentists and office owners to be making that connection with your team, even if you don't have a ton of information to share, making sure you're staying connected so they have some sort of idea of what's going on.
And we always say, when you go back as a dentist and you're in the operatory, you are managing from behind your mask, and your team is your voice. And that's why we love this risk assessment profile, because we're always on the same page, but they're always your voice. And I have full confidence in my team. We've practiced so much, and they're such A players, but I have no problem with having confidence that everyone's going to come back and be rock stars, but you have to keep that connection going through. And I think, Jonathan, you asked early in the call, a call about what do I do with team members that don't want to come back on the date that I tell them, and I just don't imagine that being an issue. And, from a legal standpoint, they're no longer your employees. So you're hiring them back. So my answer to that, because someone will ask that, is you offer them the job and you give them 24 hours to accept, and here's the start date. If they try to negotiate that, then they're not an A player. They don't belong on your team. There's plenty of people looking for work. And plenty of great ones out there.
I think you have a lot of A players out there who are in the wings waiting to hear from the leader of the group here, and transparency and honesty is so important. And like Caitlin said, even if you don't have all the answers right now, at least making that attempt so that any questions that might be brewing and maybe inflating in some of our employees' minds will be put to rest, or at least to ease during this time. Because there's still a lot of uncertainty. And like Mike said, these are no longer your employees right now. They might be rehired, and hopefully will be. But I'm sure there are a lot of people talking about some other possibilities that could occur and that are very real. So transparency and honesty is really required of leadership.
Yeah, and a lot of it with the communication, a lot of it I find is about the PPEs and is it safe to reopen? And that communication is definitely important. Zoom is free for 40 minutes for I think up to 100 people. And, I have to admit, when I see Shar start to talk, I kind of see Caitlin light up and Mike light up. And it's good to see your team members and have that conversation where you get a visual on them. I think it's fun as a team. You guys can chime in. But yeah, I think it's important. If you're not communicating, start now. Use Zoom. It's free. Paul, at this point, I want to throw it to you. You've queued up some questions in the queue. I want you to read those off and answer those for us, and then even feed a few to Caitlin and Mike, if you could, please. Paul, you're on mute.
Indeed, I was. Okay. Nothing like talking to myself. All right. Mike, this might be one for you. Is the strength of the mirror suction in between the HVE and slow speed suction?
Repeat that again.
The strength of the mirror suction somewhere between the HVE and slow speed suction.
Mirror suction.
So I think they're talking about particularly the product that is for hygiene that allows for the hygienist to see at the same time as they're suctioning.
Oh, yes. I have not tested it, but from what I've read on the stats and from what Tom Slezak gave us as the info, it is equal to an HVE tip. We have 3 on order. They're back ordered until like June 10th. But yeah, I think that's a great solution for your hygienist now that you can have high vac suction as they're doing air water syringe. And that, in our last talk, we talked about that, and the research showed it was 90 to 95% of aerosol is removed from that HVE tip. But it's got the advantage, it's got the mirror on it so they can actually see.
Hey, Caitlin, this next
pure
question,
vac, right? Pure.
This next question is for you, Caitlin. Stephanie was asking whether or not it's is it going to be important for the front office team to be really proactive when it comes to asking questions of patients prior to them coming in, just to save time on the back end once they do? And what kind of questions might those be now?
I think that's very important. I'm interested to hear actually what Charlene has to say about this as well. But I mean, for our patients anyway, before even COVID, making sure that our front office is communicating with the patients so we're all on the same page if they have issues before they come in, if they have any concerns. Again, that way we know what we're in for. But especially with this, being able to set the patient up so they understand what the protocol might be when they come into the office is going to make it so much better. I mean, how many times do we tell patients what's going on in their mouth, and we have to say it like 5 times and then they finally get it? So just making sure they're consistently hearing the same information, I think, is important.
Charlene, do you have anything to add to that question?
Well, we're consistently communicating with our patients via Weave. So definitely when we do go back in, I'll be telling them what's going to happen or on the phone, and it'll almost be scripted, but it'll be something that I'm going to have to continuously repeat to the patients because they have to know what to expect because things are going to change when they do come in. So as long as you're talking to them, they are pretty open to any changes. And I mean, you'll get 1 or 2 that are not open to it and they want to do it however they want to do it, but we'll get pretty perceptive patients with just talking and letting them know what's going to happen.
Thanks very much, Charlene. So there's another question here that has to do with what do you say to patients who are asking you, do you have this product or that product? And there's so many products out on the market now. And do you, for instance, do you have a UV light system to keep them safe? Or do you have some other type of system to keep us safe? And if you don't have that system, How do you answer that question? Mike, do you have any thoughts about that?
Yeah, that's a great question, and you can take it all the way from employing nothing and not changing a thing, which is not the standard of care, all the way to a negative pressure room, right? I mean, that's, if you really wanted to practice the safest dentistry, we would all be in a negative pressure room. Now, my wife works at UCSD Medical Center, and they have 4 negative pressure rooms in the entire hospital. So that's not going to be realistic for any dental office, nor to be able to facilitate the costs. So you have to decide what are the things that are important to you. So we do know that the surface disinfectants have been proven effective against the viruses and so forth. So I would probably preempt those questions or try to eliminate those questions as much as possible by putting forward what your efforts have been to make the areas safe. In order to disinfect the areas in between patients, we do the following things. We will ask that you wear a mask when you come in and so forth. And there's going to be a fringe, but I don't think there'll be too many. And say, we've looked into the UV, but from a time and cost standpoint, or whatever you want to say, the surface disinfectants provide a great job. It's a great question. It's not an easy one to answer.
So there's another question here that I think is a very important one. Mike, you and I touched on this just yesterday. Someone said, I don't try to introduce all the information I want my patients to have in the first appointment, and that sometimes that information is shared over many appointments. You and I had a conversation about an experience at a physician's office lately, and maybe you want to share that with regard to that.
I understand where you're coming from, because you don't want to overwhelm the patient with too much information. But imagine if you went to a physician's office and you went for a regular physical exam, and they took labs on you and they performed an exam, and he found a little lump, maybe a lump on your leg or something. And, you've got some other medical problems and so forth. And he just decided to withhold that information from you because he didn't want to overwhelm you, because it would be too much bad news. That would never happen. A physician is going to tell you exactly what his report and findings are, and then he's going to refer you to the appropriate people to be able to help you. And then he's going to give you a risk assessment based on your labs and the data that they've covered. So actually, I think it's kind of malpractice to have findings inform a diagnosis and not share it with the patient. Now, I get it. If you share too much information, you overwhelm the patient, and therefore they might recoil. But that's where the risk goes back, right? So you can talk in general terms, like, you have a lot of fractures on your teeth. I can see you've had previous work and so forth. I'm going to put you at a moderate risk. Are you at the point now to where you'd like to start to get a comprehensive lifetime plan to address this? Is this the right time for you? Now the patient's in the driver's seat, and there is no pressure. There is no contest. And now you can start to break it down, right? And start offering that for them. And we found that's worked pretty well. Charlene, have you seen any objections to us doing comprehensive care for new patients when we do it in that method?
No, actually, I do find that patients appreciate that more, the honesty. You will have one patient every once in a while just feel a little bit overwhelmed because they don't understand it completely. But what I do find is I have patients coming to our office saying, well, I left my last dentist because he just kept finding new things every time that I went in. Now, are they really new, or was it something that you guys were holding off so that way they didn't feel overwhelmed? Well, they feel like hiding stuff from them. So I do get those patients coming into our office, and they appreciate the treatment plan, and they understand this is what's more important. You can do this over time, and, we're here for you, whatever you feel comfortable with. We're not pressuring them, but they do need to be informed of what they need to get done. And that way there's no surprises when their tooth breaks later. So I definitely find that our patients appreciate it rather than become frightened of it.
Yeah, and it really, I'll just add one more thing. It really gets you out of the insurance box. Patients are, what does my insurance cover? And so, we take a lot of time, and Charlene's an expert at it, on letting them know what we don't call insurance. We call it the I word. It's the dental benefit plan, right? It's not insurance. And, we let them know that we're going to maximize their dental benefit plan for them, but these are your risks moving forward. And once they have that, they can make informed decisions about comprehensive care. You can't do comprehensive care until they accept comprehensive care. They can't accept comprehensive care until you've diagnosed and treatment planned comprehensive care. So if you don't let them know about all the wear in their mouth and the long-term consequences, why would it be a serious problem for them? So it's an art, and that's why we're putting together the workshops and so forth. And I would encourage you to sign up and bring one of your cases, and we can navigate that together and role play, and you'll see it. It's really quite easy. It's really the system when put in place that anyone can do this. Hope that answered your question.
Thanks a lot, Mike. Thanks, everybody. Great answers. Martin is asking, can we get a copy of this risk assessment form? And if we can, it's going to be on Buckets and buckets.co.
Yeah, we'll put in the practice resources. It's just one copy. I mean, I would encourage you make your own with your own graphic designer and so forth. But again, it's looking at the 4 risk factors: foundation, teeth, gums, and systemic factors that are going to approach it. And then you can have all your products on there that you recommend to help mitigate that risk. And then you just don't have to come.
So another question, it says, I'm curious, is there any way this method can be taught to new dentists and dental students so they can implement this early? Yes, if you're a dentist who is in a position to volunteer time to be a mentor to dental students or new dentists coming out of school, if you're so inclined to share this type of information and this approach, absolutely do it. There's nothing like giving to these younger dentists who are coming out of school and setting them off on the right foot.
Yeah, and I'll add that, whether it's a dental assistant, a dental hygienist, or a dentist, we go through, for the lack of a better word, a trade school to learn a craft and a trade. And I know we're doctors and hygienists and so forth, but when we first walked in there, we had layman's language. And once we went through our schooling, we developed all of this language that's pertinent to our profession. Now we have to almost unlearn it from the point of communication to where we want to make sure that it's in the terms that they understand. And that's what the art is to be able to give the information in a way that they can understand it, and then be able to make logical decisions moving forward.
Another question, would you recommend a separate charge for PPE, from Kevin? I can tell you that I just saw an announcement from Delta Dental that they, at this point, haven't decided yet whether or not they're going to be able to allow dentists to charge for that. It's still up in the air. Mike, have you heard anything different?
I have not heard anything different. We're going to take the approach of, I don't like being nickeled and dimed. I don't like going in to get an airline ticket and then all of a sudden I turn around and there's $7 here and $12 here and so forth. I remember when they instituted fuel surcharges after the oil crisis, and everyone got hit with that. I would say, just incur the cost some other way. Raise the fee of a bite wing a couple dollars or $3 here and there, and you'll be able to recoup your cost.
Dr. Mike, someone's asking what PPE you're providing and supplying with your staff, your team. And have you had any resistance? No?
He's on mute.
I'm back. Or my son's a musician. I don't know if you could hear it in the background, but I couldn't quite concentrate. So I'm back. What was the question?
Someone was asking what type of PPE are you actually bringing into our office, and has anyone on the team given you any resistance or backlash on that?
Well, I can ask Caitlin, my team, if I've had any resistance or backlash. But I mean, backlash, we're going to put in the KN95 masks and then the type 3 with the face shield. I think I'm going to guess that the dental hygienists are probably going to prefer the surgical type 3 with the face shield because it's going to be a lot more comfortable. N95 masks have to be fitted for them to be effective. And by the way, I mean, they did a study, and the number one way that healthcare personnel in hospitals were getting COVID was improper removal of PPE. So that's a major issue. So much easier to remove a type 3 mask than an N95 and so forth. But that's what we're going to employ. And then disposable gowns, we're looking into reusable gowns as well. But that's going to be moving forward. We're very lucky, not that we don't have to practice it, but we're very lucky that our numbers are very, very low in North County, but we still have to exercise the universal precautions.
There's a question here, actually several questions having to do with this. So when you go into buckets, how do you find your particular list? When you go into buckets, just search for my name or Dr. Lefebvre's name. You can find that readily and request a connection. And once you do that, we'll be able to connect you to that list without a problem.
Awesome. There is a question, a couple of questions actually about hygiene and scheduling. Has it been decided how long appointments will be scheduled for perio in order to include sanitizing between patients? And also, if it's extended, it will affect how many patients are seen in a day, as well as compensation for hygienists. Can you shine some light on this?
So it will extend the appointment if you don't have extra rooms. We happen to have an extra room to where we're going to talk in between rooms, so it won't be an issue. So I envision the hygiene appointment be the same, just that we'll have auxiliary flipping the rooms. And so we'll have that 1 hour break in between those rooms moving forward. If you do the room and you have to increase the time, then obviously the production is going to decrease. I shared this last time in part 2. I don't believe in tying a hygienist compensation to their position from the standpoint of if there's a hole in the schedule. I think if you make an agreement with your host, then getting that rate of pay and we pay them unless there's some arrangement that's made. But it's not their fault that someone canceled. So that's the team approach to be able to do that and to be able to have that ASAP list to be able to fill it. So I would move forward with respect to your hygienist, be the rock star that she is.
There's an interesting question here I just want to share, and it's an anonymous attendee. Super important to be flexible in treatment when looking at this from a patient's perspective, especially when it involves money, low income, fixed income, et cetera. Need to provide more than 21st century options. Partial dentures, Maryland bridges can still be viable, less invasive, less expensive options that'll still work instead of implants. If a patient really has issues, is reluctant, can't be flexible, keep the patient in your practice and not break their bank. The older modalities can still provide a viable option. That is a super important point, but I think it also falls in right underneath what we're saying in terms of this risk assessment model. You are empowering your patient to make decisions with you. And when I was talking about beneficence combined with this risk assessment model allows everybody to come to treatment decisions that are in the patient's best interest wherever that patient is at. And this presentation, I hope, did not convey that we're trying to not value these patients. These patients are family. And
on the contrary,
long-term relationship.
Yeah, and that's a great point that the person that posed that question. I mean, that goes back to the alternatives. But what's interesting is when you go to that risk assessment, you're also given an outcome assessment, right? Because given all things equal, people usually want what's going to last the longest. And if you give them an option, for example, a composite filling versus an inlay, right? So now fillings are usually widely used more than inlays, but we know inlays last a lot longer. But do you offer an inlay every time to your patient? Why not? Why not? What would you put in your mouth? We can't diagnose the wallet. Patients that thought 1 crown was expensive, and then all of a sudden we get into a comprehensive plan, and they're like, there's some money around, but I think do the 8 veneers. And I mean, it wasn't anything I did. I just showed them the issue and showed them what's going down the line. But you're absolutely correct to point out there are all alternatives that have served us very, very well. Next question, Paul.
Yes, recommendation by somebody. There's a book called You're Not Listening, What You're Missing and Why It Matters by Kate Murphy. Someone who worked for a highly stressed dentist who is very clinical in nature and a low emotional quotient. And this book transformed the way that this person practiced and had wonderful results as a result.
Thank you so much for that recommendation. In fact, we're starting to dive in. We're kind of building an Apollo book list. We recommended the Checklist Manifesto last time. Fantastic book on why checklists are needed. It was actually done by a cardiologist or heart surgeon in a hospital. We recommended the one today, The Power of Habit, and The Obstacle is the Way. We've been looking for great recommendations for something like this, so I appreciate that. We will read that and we will add it to the list and sure recommend it. Thank you so much.
Another question is, I know no Cavitron will be used. How about teeth polishing? And if no, how do we make them feel it is satisfactory? There's a satisfactory cleaning being given without polishing.
Caitlin?
I mean, we always go back to that polishing doesn't actually have a therapeutic benefit. And I actually, there's some patients that think that is the main thing of the cleaning, and I know that. But if you're telling them that you're not using it because you're reducing the risk, I think they're going to understand that. And I think you just keep going back to what you're doing and why it's important for them.
Yeah, with HVE, I mean, polishing may not be that much of an issue.
Mm-hmm.
I think we're gonna have to look at it in the chair and see if it's something that we're comfortable with. I will recommend another book on that, but another book by Simon Sinek, Start With Why, goes into why we do the things we do, and you lay out your vision first and then work from the inside out rather than what you do. People buy why you do it, not what you do.
Mm-hmm. Someone asked for the mirror suction, the name, and we're using PureVac, right?
That's correct. Order. Yeah, Tom from Patterson Dental brought that information. It's great info.
Here's a question. What are your, by Shade, what are your thoughts on patient pre-rinse with hydrogen peroxide before treatment? And do you think 3% is good enough?
Well, the American Dental Association recommended pre-rinse of chlorhexidine, but chlorhexidine doesn't kill viruses. So if you want to decrease the bacterial load, but that is shown to be largely anecdotal. There's no study to support that really is to do anything from a viral spread standpoint. Now, it's good practice, and it's another on your toolkit that you're showing that you care, but that's what the studies show.
Yeah.
Another question here by Ramin. He's saying that over-counter UV lights are ineffective. UV lights used in hospitals are special lights which we do not have access to. These lights will burn your skin in seconds, so most lights on the market are not effective against COVID. From my understanding, yes, there are hospital units that could work in a dental office. They're probably cost prohibitive, but they do kill COVID virus without a doubt. But you need to have a closed room for that to be emitted, or you have to be out of the office for 30 minutes. So it's not very practical. If you're looking
and hospitals have trained personnel that that's all they do. I mean, they really, as far as in OR and so forth. I mean, that person's dedicated to doing that. We're just adding these new things in. I think we stick to what we do best. That people are used to disinfecting an operatory, and that's where we should focus during this hopefully short time that this is with us.
Priscilla was asking, Caitlin, this might be going for you. Do you think your hygienist will be using a level 3 face shield even when they start using piezo Cavitron again?
I don't know. I mean, I think we can only plan so far ahead. So I'm not sure. I'm not sure, Dr. Mike, if you have any thoughts on that.
So there was a study done by Rilla Christensen on the Buckets website and the practice resources that actually looked at all of these questions. And that study came out of SARS and H1N1. And they kind of looked at what was the most effective. They actually looked at mass rather, the only masks that allow the aerosol to go through. But as soon as you see the area, the stained blue, as soon as you saw the stained blue aerosol that got through the mask, you probably wear a face shield again. I mean, when you look, it's pretty compelling research.
A real interesting question from Renee. This goes out to anybody here. Do you think periodontal scaling and root planing should be delayed, if possible, to a later time when ultrasonics can be used more easily?
Well, I think, ultrasonics do a great job. It's very efficient removing that, but I think Caitlin can chime in. There's nothing better than hand scaling for the tactile and making sure that everything is removed. They were doing root planing before they had cavitrons, so I would delay treatment of an infection because we don't have a instrument of convenience, we'll call it that. I mean, I know there's some therapeutic value with irrigation of chlorhexidine and so forth, but in our office, we're going to hand scale and we will continue to do root planing the old way. Obviously, we're going to have to allow some more time.
As far as a standard of care, does hand scaling still float the boat?
Caitlin, I'll throw that out to you.
I'd say I feel comfortable in a lot of my patients hand scaling when I'm doing scaling and root planing. And going back to that previous question, they have active infection. So are you gonna keep their active infection in the mouth because you can't use, like Dr. Lefebvre said, a cavitron, or are you going to help reduce their risk and move them towards health? And I think that's our primary goal. So that's my thoughts.
I concur.
So this is a human resource question. It's, I think, pretty pertinent. Assuming the stay in place is lifted May 31st and we can return to see patients on June 1st in California, can we require our staff to come in 1 to 2 weeks prior for paid training while stay in place is still in place, as long as we're not seeing patients yet?
Can you repeat that again? Can we require and start from there?
Yes. Can we require our staff to come in 1 to 2 weeks prior for paid training while stay in place is still in place, as long as we're not seeing patients yet? Would we be violating the stay in place order by doing that? And if they don't want to come in for training prior to stay in place being lifted, then what would you recommend?
I would defer to someone who's an expert. That's a great question. As someone who's an expert in human resources on that, you have a responsibility to put the stay-at-home order and follow it. It's new that there hasn't really been any laws tested and so forth. That's a great question. I mean, we're moving into stage 2 and 3 now. So, boy, I know a lot of dental offices that are open right now doing cleaning. So, I think that if you maintain I'm just thinking through this now. If you're maintaining a safe distance like you are in a grocery store, I don't see any reason why you couldn't conduct meetings, especially if you started with Zoom and then you started to do some issues. I think that would be safe. But I would consult with your HR consultant on that to make sure that that is appropriate.
Thanks, Mike. And hey, and this is to you, Caitlin. If you can't polish, how do you clean a pediatric patient?
We actually don't have a lot of pediatric patients in our office, but I think you can still clean their teeth without polishing.
And no therapeutic value to polishing, right? Just remove stain and it makes them feel like they got a cleaning. And you just have to let them know why you're doing it. This is hopefully going to be a short-term issue. We're talking maybe 2, maybe 3 visits, total. So, I think you just have to take that into account. But we'll be looking into that as far as, the aerosol produced by prophylaxis. So it's a great question.
Interesting question for the clinical team again. Will the RDH use lasers more frequently since cavitrons will not be used at this moment?
We use the lasers regularly anyway for those patients that do need it. So we'll continue that.
Yeah. Two different methods though, right? So laser is the disinfection and killing the below the gum line, whereas the cavitron would be the mechanical removal of that. So it would be two different kind of skill sets in that. We use both of them though. We use we call it laser periodontal therapy instead of scaling and root planing. Again, we'll talk about that in the workshops as well, using patient-centered words. We don't use the word cleaning and insurance and so forth. But yeah, if you have a laser, that would be implemented in every periodontal therapy session.
Perfect. And we're moving towards, 2 hours on the call, which is fantastic. Lots of good questions. Still a lot of people still here. I understand that Caitlin might have something to tend to, and I definitely want to give her a chance to talk again about what she does to calm the office and some of the yoga before she has to leave us. So Caitlin, if you could do that, we'll get back to a couple questions and we'll wrap it up.
Okay. I think that it is so important, especially if you guys have been on the last two. I shared a little bit more about what I do, but in addition to being a clinical hygienist, I am also a yoga therapist and work specifically to support dental professionals in reducing pain and discomfort in their body and also stress throughout the day, because we know that there's already so many things in dentistry that we cannot control and that happen inevitably, right? Late patients can't get numb, we're inundated with phone calls, all of the things. So making sure that for everyone on the team that we are calm, that we are relaxed, that not only we have a plan and we're prepared, but making sure that you're relaxed so you can be present and you can be really grounded force for your patients. Because if your entire team goes in there and everyone's stressed, never mind half of your team doesn't know if they feel safe or if they feel safe supporting your patients are getting mixed messages. Your patients aren't going to feel safe. So yeah, I think one thing that we're talking about implementing and that I've created is different like breathing practices, a simple meditation that can be literally as easy as like a minute long to do in your morning meetings, in your morning huddle or whatever that looks like. So that again, your entire team is really focused, is really present, is relaxed as we can be, of course, in a high-paced environment. And yeah, your patients will pick up on your nervousness or your stressedness. And if the whole team is on that way, and things get thrown in the court, which it'll inevitably will, we're not going to be able to respond and communicate as properly as well, I guess. So meditation, breathing can be simple, profound.
And we have
Perfect.
that. We do have the link to all of Caitlin's info as well on buckets as well when she presented that. So if you want more information, you can go there or go to her website as well.
Perfect. So Paul, I'm going to throw it over to you. Are there any really good questions? There's tons of good questions, and I can't say it like that. But are there any questions you feel we really should answer? We'll do a couple more, and then we'll move to wrap it up.
Yeah, sure. There are a lot of questions here. One question that I think is probably going to be a popular one here is, in an office that patients get scheduled 6 months ahead, how will patients that were canceled during the COVID shutdown be accommodated? I know we touched on this a little bit today and a couple sessions ago, but Charlene, you might want to chime in on this one.
Well, the biggest difference I've seen on other offices and what they've chosen to do with their patients that they did just cancel is I came and I rescheduled them in the hopes that we would be opened again. So they do have an appointment on the books in the future. So our books are pretty full right now. And the hope is that Dr. Lefebvre and, we'll know the date that we're going to open, and our priority patients, the perio maintenance patients, are the patients I'm going to pull up from their existing appointments. So none of the patients feel abandoned. If you did cancel those patients, what I would do right now is try to get them back on your books for any time within the next month or 2 months, whatever you guys feel comfortable with. And then when you do have an open date, you can just put them on an ASCP list if you have Dentrix, and then just call them and get those priority patients in. And that really keeps me in the loop with what they need, if they have any toothaches or anything that needs to be talked about, and I've had great communications with the patients, but I've heard it both ways. For me, what worked best is just keeping them on the schedule. If you don't have them, I would start getting them back onto the schedule right now.
Thanks very much, Charlene. Appreciate it. Another question from Catherine. Do you have any resources for finding hygienists that are looking for work in the San Francisco Bay Area? I imagine many places across the state.
You're in mute, Dr. Mike.
Mike, you're on.
Sorry, we always post, and I know a lot of people are posting on Indeed. Indeed.com seems to be where a lot of dentists are going to post their ads. So I think that would be the best place to search.
Perfect. Paul, any really good questions that you see there? I see Ramin's asking, I'm on buckets. I have not found anything under your names. What am I missing?
Just email us. Just email Paul directly, and he'll get you set up. He'll take care of you.
Yeah, thanks. Ramin, just email me directly. That'd be great.
Awesome. Perfect. So, there's a lot of good questions. I wish we could cover them all. We covered about 40 questions. There's still about 20 there. I apologize to those that submitted a question and we didn't get to answer it. I'm going to see if we can get these guys to come back for flipping the switch part 4. We'll see if we can do it. There's always a good response when these guys come on, because it's just amazing stuff, amazing content. I've seen consultants for 20 years, and I've never seen anyone with this intuitive angle of the patient's perspective and actually what's happening in the office. So, with that being said, I want to throw it to each of you for about 20 seconds, some parting words of wisdom, a final goodbye, and then just a really quick shot on how to reach out and find you. We'll go ahead and start with Paul, then we'll go Caitlin, then Charlene, then we'll finish with Mike.
Well, thank you very much, Jonathan. It's been a real pleasure being here these last few weeks, and looking forward to being a part of your hopeful solutions going forward. My parting words of wisdom really is to take a big, deep breath and be sure to be rested and try to have a clear mind as you go back at whatever time you end up getting back at your office, and be patient and forgiving with yourself and with one another. This is going to be a major adjustment in terms of procedures and in where people are in their lives. So be patient, forgiving, and move forward, and we'll get past this.
Caitlin, go ahead, please.
Yeah, Paul kind of took mine. Take a deep breath. And I think that's the biggest thing is it's important to stay communicated, to have a plan, and also to make sure that you're taking care of yourself, that you're ready to pivot, and that your team understands that as well, and just staying on the same page as your team and making sure that they're also taking care of themselves, because when you show up and feel good and you're ready to go and you're a team, your patients are going to get that, and the difference in the care and the quality care your patients get is going to be drastically different and better. Thank you.
Awesome. And then, one of the most important team members, when we walk in the front door, the first person we see, the smiling face of the office manager, possibly. So Charlene, what do you have for us?
Right now, my parting words of wisdom are to stay connected. Stay connected with your patients, stay connected with your employees, stay connected with one another. It'll get you through this, and it'll get you ready for what's coming, and let's get excited. We're going to start helping patients pretty soon, right? So I'm happy, and I'm sure you guys are all looking forward to that too.
Awesome. And last but not least, Dr. Lefebvre, I always enjoy the time that I spend with you, because I feel like I walk away a more enlightened individual, and especially on the dental profession. So with that being said, you want to take us home? Let's do it.
Sure. Well, it can't be done without my fantastic team and Paul, who I've known for, 25 years since dental school. And I'm very blessed to have all of them in my dental circles and friend circles. And, and it's all fostered and evolves from communication. And all of these, part 1 through 4 series, we've been so lucky that Jonathan's given us this platform. But we really focus on excelling in communication, and it's most problems between employers and team members and in between team members and so forth. And the dental office and patients and so forth, it's really all a communication problem. When you look at all the lawsuits, and it's because someone didn't listen. And kudos out to the person that gave us the recommendation for that book, because that is what it's all about. When you start to listen to your patients instead of just hearing them, things really change. And you're now working collaboratively with them, working collaboratively with your team. And so I would say just continue to nurture that communication skill set like you've done your dental skill set, and you'll just reach stars.
Awesome information. On behalf of all the people that attended, up to 300 at one point, can't thank Charlene, Caitlin, Mike, and Paul enough. Amazing information, always intriguing. I hope we can have you guys back. I'm going to have people email me if you want to see these guys again. Send me an email. I'm going to forward it to them, and we'll put our hands together through email to have an encore presentation and get them back before these offices reopen. With that being said, I can't thank you all enough for attending. And again, spend this time wisely. CE information like this is invaluable. Spend time with your family, enjoy them. We're never going to have a time like this again. And I thank you all for attending. So with that, I'm going to let everyone undo their mics, a collective together goodbye. And we're going to wrap it up and amend the call in about 5 seconds.
All right. Thanks, everybody. Goodbye.
Thank you. See you next time.